afternoon, everyone. This is Dr. Sneha from Alleviate Pain Management Center, Bangalore. Today, the topic of discussion is evaluation of back pain. As we all know, back pain is one of the commonest causes where any patient presents to a pain clinic. So, this is very important topic to know the evaluation of the back pain. So, we'll go through the topic under the following headings. First, about the causes, then the red flags, then coming to the history, and then the clinical examination, which is very important part of the evaluation, then the investigations and the diagnostic interventions. This is also very important part of pain physician to come to a conclusion of any diagnosis. In the past, more than 80% of the back pain had no specific diagnosis. Like in many of the in 1980s, in many of the pain medicine books or orthopedic books also, most of the back pain had no specific diagnosis. But now the concept has changed. Now because of the concept of the pain generators, in more than 80% of the situation we can identify the nociceptive pain source. So the evaluation of the back pain, the concept has changed now. And let us come to the back pain causes. And more than calling it as a cause, we can term it as back pain generators, because this is more relatable than calling it as causes. First, let us see what is actually a pain generator. For any anatomical structure to cause pain, it should have some abnormality. So it must have a physiological nociceptive innervation, or the anatomical structure, maybe it may have a pathological innervation or sensitization to become a pain generator. So let us see what are the pain generators at the lower back. First, common causes like the disc or the facet joint involvement, sacroiliac joint or myofascial pain, ligaments, vertebral body, bursae, or the back pain can be referred from the hip joint also. Two things are very important for any pain generator: from where the pain is coming and why that pain generator is causing the pain. And first important thing, any patient coming to us, walking to the pain clinic, we need to rule out the red flag signs in the back pain. So the red flag signs mainly are, it can be a major trauma, it can be suspected tumor, infection, fracture, any neurological deficits, it can be autonomic, motor or sensory involvement. So it is very important for any pain physician to rule out these red flag signs before going ahead with any intervention. Now coming to the general history. First, we will start the evaluation of the patient by asking their chief complaints. So, in history of presenting illness, the intensity of the pain, the quality, and the factors which are aggravating the pain and relieving the pain, and we can scale it on a numerical rating scale from 1 to 10, so that we will have an idea about the intensity the patient is suffering from. And also the diurnal variation of the pain is also becomes an important factor. Then the family history of the patient or any medical issues and the personal history of the patient also becomes important, and occupational history, especially if the patient is working from home, sitting long term, and the posture becomes important related to this occupation. Working in front of the laptop, having back pain, all these things becomes very important to come to a conclusion. Now coming to the examination steps. First important is is to follow a routine protocol for any patient whom we are evaluating. So the steps we need to follow are inspection, then comes the palpation, then range of movements, then neurological examination, and then comes the special tests, which are very important to come to a conclusion of the diagnosis. And in inspection, first we will examine the posture of the patient. Then the gait becomes very important. Then the muscle shape and the size and the contour. And in any back pain, we need to examine the back and the limb color and presence of any swelling, scars or sinuses. Then comes the palpation. In palpation, we need to focus on the tenderness of the joint line, then the bursa and ligaments, and any involvement of muscles or tendons. Then comes the range of movements. We need to examine the range of movements in hip, spine with the flexion movement, extension, rotation, lateral flexion of the spine, adduction and abduction of the hip. Then comes the neurological examination. In this also we need to follow certain protocol. First we need to check the higher mental function, then the cranial nerve examination, then examination of upper and lower limbs, then comes the sensory examination, and motor examination is very important. In motor examination, the power of the muscles, then the superficial and deep tendon reflexes becomes very important. Then special tests have its own importance in coming to any diagnosis. This includes tests for the lumbar nerve root irritation, tests for the SI joint pain, tests for spinal canal stenosis, and then the test for piriformis myofascial pain syndrome. Coming to the straight leg raising test. This is actually called as Lascigue's straight leg raising test. This test is very important in diagnosing if there is any nerve root compression. So any nerve root involvement, this SLR test will be positive. In this SLR test, we will ask the patient to lie down supine, and then we will hold the patient's foot at the ankle. Then we will ask the patient to flex opposite knee, and we will raise the patient's leg without flexing the knee joint. And if the patient experiences the pain in the back, this indicates the positive test. And there is crossed SLR test also, and it is more specific for the diagnosis of the nerve root irritation. Then coming to the tests for spinal canal stenosis. In spinal canal stenosis, due to the pathology, the patient will actually experience the pain, neurogenic claudication kind of pain after certain distance of walking. After certain distance, when the patient complains of neurogenic pain, we can ask the patient to adopt a stoop posture, and that will relieve the patient's pain. And when this is positive, we can come to a conclusion of the spinal canal stenosis. Now coming to test for SI joint pain. There are a lot of tests to diagnose the SI joint pain, like distraction test, thigh thrust, sacral thrust, Jane's test, compression test, and the Faber test. This we commonly use this Faber's test to clinically diagnose this SI joint pain. This Faber test is done with the patient in the supine position, and we need to flex the patient's affected limb, flexion at knee and the hip joint, 90-degree flexion, and we need to do abduction and external rotation. This maneuver will make the patient experience pain in the back. So if this test is positive, it favors diagnosis towards the SI joint pain. And now coming for the test for piriformis syndrome. Freiberg's test and the Fair test are done. In Freiberg's test, we are internally rotating at the hip joint, and the patient will complain of pain at the buttock. So this will be a positive if the patient is having piriformis syndrome. And in the Fair test, this is usually done in the patient lying in the lateral position. We will flex the patient's hip at 60 to 90 degree, and knees also 60 to 90 degree flexion, and we will do an adduction and internally rotation and apply pressure at the hip joint. This will reproduce the pain if the piriformis muscle is under stretch. So this Fair test positive will indicate the piriformis syndrome. Coming to the disc as pain generator. Again, why the disc as the pain generator becomes very important. The most common cause is internal disc disruption, which is commonly seen in the middle age group, like a patient walking to a pain clinic around 30 to 40 years of age, complaining of the low back pain, which is diffuse in nature. Then the diagnosis favors towards the internal disc disruption, commonly termed as IDD. Then comes the disc prolapse, which is again a very common cause of the pain arising from the disc in elderly age group. Then comes the lumbar canal stenosis. This diagram shows the picture of the nucleus pulposus and the annulus fibrosus, and we can also appreciate the exiting spinal nerve root. And this is the sympathetic nervous system. Since the disc has the sympathetic nervous supply, the disc is supplied by the sinovertebral nerves, which is again the branches from the gray rami communicants. So this is a part of the sympathetic nervous system. That's why when disc is the pain generator and when internal disc disruption is the like a cause for the pain, then the pain generators are the nerves inside the disc. And since this is the sympathetically mediated pain, the patient will experience diffuse low back pain. So this favors towards the diagnosis of IDD. And when in the disc prolapse, the pain generators are usually the nerve roots outside the disc. It can be exiting nerve root also or the traversing nerve root also. And in lumbar canal stenosis, the pain generator is due to the ischemia of the nerves because of the compression. Coming to clinical features, again as I already told, in IDD or the degenerated disc disease, the patient will experience back pain in sitting position. And in disc prolapse, the patient will complain mainly of the leg pain or the back pain which is radiated to the leg pain. So this is the typical radiculopathy pain, which is relieved on sitting or lying down, and it will increase on standing and walking. And in lumbar canal stenosis, patient will give the typical history of neurogenic claudication. The patient will complain of the leg pain which increases on walking, and this will be relieved in sitting position and it increases again on standing. Now coming to the facet as pain generator. This facet joint, why the facet joint can be a pain generator? There are multiple causes like degeneration. It can be due to facet joint arthritis, which is one of the most common causes of low back pain in elderly age group, and it can be due to inflammation like spondyloarthropathies, which can that time facet pain can even be in the younger age group also, or it can be due to trauma. Coming to the clinical features, the patient will typically complain of predominant back pain, which is non-dermatomal leg pain, and this pain is relieved on sitting and bending forward, and this pain will increase on extension, lateral rotation and bending also. So this facet loading test becomes very important in diagnosing this facet pain, where we ask the patient to stand and do the extension, and in extension position we will ask the patient to do rotation, and this will reproduce the same pain, and this pain is decreased on walking, and this pain will not have any neurological deficits. Now coming to SI joint as the pain generator. So SI joint, again, why the pain is arising from the SI joint becomes very important. It can be due to degenerative changes like SI joint arthropathy, or inflammation like spondyloarthropathy, or it can be due to trauma or malignancy. Coming to clinical features, patient typically complains of low back pain and buttock pain, which is well localized, and it will be non-dermatomal. And this pain is increased on sitting and relieved on standing or walking. This will again have no neurodeficits. And muscles can also be the cause of pain. Myofascial pain is also one of the common causes of low back pain, and this can also be due to repetitive stress injury, trauma, and the prolonged muscle spasms or malignancy. Coming to ligaments as pain generator, it can be due to sprains or trauma or enthesitis. Then a vertebral body as a pain generator, it can be due to trauma, fracture or malignancy. And bursae as the pain generator. This can also be due to trauma or any inflammation, like the greater trochanteric bursa, which usually can present as low back pain radiating to buttock pain. And hip joint as pain generator. This can also be due to trauma, inflammation, involvement of spondyloarthropathies, or due to degenerative changes. And this hip pain can be referred to the low back. Now I want to tell something about myths which are commonly associated with the back pain. We have any common man will have will come to pain clinic present to us with an MRI when they have an acute back pain. So they think that MRI is must when patient presents with acute back pain, but this is the very big myth, and 80% of the diagnosis can be made with history and clinical examination, and MRI is only indicated in some cases, and it will be always a supportive diagnosis with our clinical examination. So this is not must whenever a patient presents with acute back pain. Then coming spondylosis. This term is a layman term, and spondylosis can be used as a terminology for any inflammation associated with the spine. And people think spondylosis is the most common cause of low back pain. Again, this is a myth. The most common cause for low back pain in the elderly age group is facet joint involvement. It can be due to facet joint arthropathy, and in the younger age group, the most common cause can be due to internal disc disruption. So we need to limit the use of the term spondylosis, and we need to be more specific in our clinical terms. And it is commonly thought that complete bed rest and restriction of bending and other movements is indicated in any patient in back pain. This was the concept in the olden times, where complete bed rest was advised for any patient presenting with back pain. Now the concept is totally changed, and according to the international guidelines, more than 24 to 48 hours of bed rest is never advised in any acute back pain. In fact, the more bed rest will cause more harm than the benefit. And use of the lumbosacral belt helps in reduction of back pain is also one common man's thinking, and this is also not advised to use the lumbosacral belt, because lumbosacral belt usage for the prolonged time will cause deconditioning of the muscles and result in disuse atrophy. So this will result in more harm than the benefit. So we should not advise lumbosacral belt for any back pain patients for long term. And coming to posture, it is always thought that we should always sit straight to avoid back pain, and this is also a myth, because sitting too much straight or bending forward and stooping, both can be harmful. So the best position, the best posture which is advised for the patients is always a changing posture. So the changing posture keeps the intervertebral pressure keeps changing with the change in posture, and this will make the spine healthy. So walking is the best exercise which we can advise for any patient who wants to have a healthy spine. So the posture should not be always straight to avoid back pain. This was my discussion about the evaluation of back pain. Thank you, everyone.